pain clinic and multidisciplinary pain approach. For chairing this session, I want to call Dr. Ashrukana Mitra, Dr. Deepak Roy, and Dr. Jayanto Mitra. I think I have seen both of them, but only Madam is here. Madam, please come to the stage. So far I know about Madam, she is the ex-HOD, RG Medical College. In her initiative, he has first started the critical care in RG Medical College. And more than that, she is long associated with Daradia Pain Clinic, Pain Foundation, and everything in Daradia. So she is well present here. And moreover, she was the ex-president of ISSP. So Madam, to you.
Good afternoon. The first speaker is Oyanangshu Nayak. Please come and deliver your speech.
Dr. Oyanangshu Nayak is a leading psychiatrist of the city, and she is working at various places in Calcutta. She was associated with the pain clinic in UK as well.
Hello. Good afternoon, everyone. Thank you, Debojyotita, for your kind introduction, and Madam. Today I'm going to talk about placebos. What, where, when, how, and why. I only have 20 minutes here, and I intend to keep time, and therefore it is not possible to discuss an exhaustive treatise on placebos. I hope I'll be able to give you a flavor of placebo, but not deal in superficialities such as color, capsule, tablets, etc. We hope to go beyond that. So, what? Definitions. Interest about placebos has existed for millennia, and the word actually comes from Latin, the meaning of which is I please, or I aim to please. Multitude of different definitions have been tried, but none have been found to be absolutely that describes what's happening here. Some of the examples are a trickery, a sham, an arm in an RCT. Anyway, I have got one particular definition here that's somewhat captures what placebo is, which is a range of evolved behavioral responses subject to natural selection, allowing the organism to regulate investment in self-healing processes according to favorability of environment and prospects for recovery or further threat. Even this definition has limitations. For example, it doesn't take into consideration the investigator-related effects. Moving beyond definitions, a little bit of history. As I said, curiosity existed for actually millennia. It's associated with ethical dilemmas. We know it works, and we know that we shouldn't trick our patients. So what do we do about placebos? We are still trying to deal with this. It's almost universal in all societies through ages, and the most important modern paper came in 1955 by Henry Beecher, The Powerful Placebo. He was an anesthetist, and actually from that paper our current understanding of placebo began. So, where do we see placebo effects? In anesthesia, in pain management, we see it. In depression research, in psychiatry, it's well established. In neurology, in Parkinson's disease, for instance, actually some of the greatest placebo effects come in surgery or surgical procedures, such as a paper was done in 2007 on spinal fracture cement treatment, vertebroplasty operations, where the impact of placebos were some of the highest anywhere that has been measured. Sports performance. Now, this is important. My interest in placebo began when I learned that before the London Olympics, UK Olympics team was actually researching with placebos to enhance performance in Olympics. So that is where it was well researched. Again, in immunology, dermatology. However, we have to be cautious because there are some areas where placebos just do not have any effect, such as cancers or HIV. So, impact of placebos. Now, it's quite heterogeneous, context dependent as well as content dependent. So, rather than talking about impact or effect sizes in absolute terms, i.e. numbers, I've given you a comparable comparator table where I have listed more and less. For instance, physiological, where we are measuring heart rate or blood pressure, it should be blood pressure, sorry for the typo, it varies more with placebo, or placebo effect is typically more than in biochemical parameters, for instance, liver function test. Physical placebo interventions, I've already spoken about surgery or acupuncture. We would expect it to be more than when we are giving pills. When the effect is patient-rated, it is typically more than when it is observer-rated. Small trials, particularly trials measuring placebo response, the effect sizes are more with small trials compared to large trials. I have already mentioned explicitly measuring placebo effect. Those trials typically have more placebo effect than one arm of RCTs. Where patients, well, hidden trials show more placebo response than open label placebo trials. Now I'm going to talk a little bit about additive model of placebo, which came about from a paper by Ernst and Resch in 1995. Because it is an additive model, I've put lots of plus signs. So unidentified parallel interventions plus time effects per natural course of the illness plus regression towards the mean, we call them together, we lump them together as non-specific effects. And true placebo effects plus this is perceived placebo effect, which is what we see in trials. Now, perceived treatment effect would be true treatment effect plus perceived placebo effect. I've tried to, I'm so keen and I wanted to express my artistic side so much that I drew it with my hand. I'm not sure whether you can make much meaning out of it, but suppose this is a trial, RCT, and if the top line, one with the green, is the total effect we see, the middle line would represent the perceived placebo effect, and suppose the last one would be a non-treatment arm, the effect there. Again, if you can see a visual representation of that, so other effects plus true placebo effect is perceived placebo effect. And again, perceived placebo effect plus true treatment effect is perceived treatment effect. Now, there might be a question, what is independent effect and why does it happen? One thing is natural course of the illness and variation of the disease. Now, it is not counterintuitive to think that patients are generally recruited most likely when their symptoms are at their highest. And therefore, it is not unlikely as in 2 or 3 months' time, actually when the trial is midway, that their illness or the symptoms have come down. It can go up, but usually that effect is generally from higher to lower side of symptoms. Regression towards the mean. I mean, it is a complex statistical concept, but if I tell you one thing, just to intuitively make you aware of it, which is, suppose if I take a coin and toss it 10 times, it is likely that you won't get heads or tails 5 and 5. But if you do it 1,000 times, can we keep quiet, please? If we do it 1,000 times, it is more likely that the numbers would be 500 each, or closer to that. So, what happens is that the effect of chance evens out as more and more patients are recruited and the trial goes on for some longer period of time, and regression towards the mean plays a part. Time effects are, as I said, worse during recruitment, improving skills of the physician or the interventionist. For instance, if it is a surgical trial, that's what we see. Now, Hawthorne effect is a non-specific event that's quite important because having been assessed and taken into a trial arm is a big thing for patients. They tell their family members, oh, I have been recruited. I've been recruited in such and such trial. And that has an impact on their lifestyle. For instance, some people leave smoking, some people reduce their drinking or stop it, they start exercising more, and it's like Schrodinger's cat, If you don't take the patient into an active arm, i.e. placebo or treatment arm, you wouldn't see that. Whereas once you do that, you are likely to see this effect. I just want to move beyond additive model because in real life, the interactions are more complex. And I'm going to tell you a couple of scenarios. For instance, imagine an RCT with two arms, one an active treatment arm and another is the placebo arm. Now, placebos can be two types. One is active placebo and the other is inert placebo. Active placebos are which have some side effects. For instance, in antidepressant trials in psychiatry, you typically expect some anticholinergic side effects of placebos. What happened? There is expectancy theory. So if it was inert placebo, that often results in unmasking or unblinding of the trial because the patients themselves start to suspect that, well, nothing is happening to me, therefore I'm probably on the placebo arm, and therefore their expectation level drops down, and therefore they don't improve much. On the other hand, if it was a placebo with a side effect, that happens less. But suppose there is, let's go beyond this actually, suppose there is a trial where there is effectiveness of the treatment arm. Suppose the antidepressant is actually quite effective. What happens there is that patients start to improve. And as patients starts to improve in the treatment arm, the placebo effect takes hold in the treatment arm rather than in the placebo arm. And because they notice, suppose depression comes down from 7 to 6, they start to rate themselves 4 or 3 simply because they expect to be even better than at any point they are. So therefore, it's quite a dynamic and mutually interacting thing that happens in real life. And I want you to think about placebos as quite a complex thing, and the mechanisms are quite complex as well. You probably have heard about proglumide. I'm not going to talk about that today. So what happens? Neurobiological explanations of placebo action. For instance, in pain, activation of endogenous opioids. In Parkinson's disease, there's more release of endogenous dopamine in striatum. In depression, for instance, in striatum, you see release of neurotransmitters such as serotonin or noradrenaline. In anxiety, which see changes in anterior cingulate or orbitomedial prefrontal cortex. Extensive work has taken place with the help of functional MRIs or positron emission tomography or other such scanners. Let's continue with this. It's important in addiction psychiatry, in cardiovascular system, in respiratory system, immune system, endocrine system, in physical performance, and even in Alzheimer's disease.